Hello, everyone. You are welcome to another session of ISSUP Nigeria bi-monthly webinar tagged ISSUP Knowledge Update Series. This is the 15th session. Excited to have you with us today. Today, we shall be looking at another very important topic, which is substance use disorders, SUD in schizophrenia, current approach to management. This is a very important topic going by the current trend of the prevalence of schizophrenia, especially among people with substance use disorders. And you will agree with me that this topic is coming at the right time. To lead us in today's discussion is Dr. Oderinde, and to join me in moderating is James Harvey. James is ISSUP International Communication and Marketing Officer, and our presenter, Dr. Oderinde Kehinde. Here is his brief bio. Dr. Oderinde graduated from Ladoke Akintola University, Ogbomoso, Oyo State, Nigeria, with a Bachelor of Medicine and Bachelor of Surgery, MBBS, degree in 2007. He completed his one-year medical internship, housemanship program at the University College, UCH, Ibadan, in 2008. Dr. Oderinde started his postgraduate residency training in psychiatry at the teaching hospital, at the Federal Teaching Hospital, Ido, Ekiti, in 2010, and passed the Part 2 examination of the West African College of Physicians, thus becoming a fellow of the West African Postgraduate College of Physicians in April 2015. Dr. Oderinde obtained certificate in global mental health from the University of Washington. He was a pioneer consultant psychiatrist in Yobe State University Teaching Hospital, Damaturu, Northeast Nigeria, where he made a significant contribution to the establishment of substance abuse treatment services in the tertiary hospital. Dr. Oderinde currently serves as a consultant psychiatrist at Addiction Psychiatry Unit of Mental Health Department of the University of Benin Teaching Hospital, Benin City in Nigeria. He has presented papers at several conferences and has scientific publications in local, national, international journals. Given his strong interest in substance use psychiatry, suicidology, and child and adolescent mental health, he has devoted much of his work to improving substance abuse treatment, education, rehabilitation, and research unit at the University Teaching Hospital in Benin. Dr. Oderinde is the chairman of Medico-Religious Collaboration Committee of Suicide Research and Prevention Initiative of Nigeria, an academic research member of Nigeria Society of Addiction Medicine, and a member of International Society of Substance Use Professionals. Today, we are glad to have you, Dr. Oderinde. Over to you, sir.
All right, thank you very much. Thank you very much, Ejikeme. Good day, everyone. First, I want to thank the President of International Society of Substance Use Professionals, Nigerian chapter, Dr. Martins, for the invitation as a panelist for today's webinar. And of course, I want to thank the leadership of ISSUP Nigeria for the opportunity to share knowledge on this very reputable platform. I don't take it for granted. Thank you very much, Olivia, Dr. James, and James Harvey. I'm Kehinde Oderinde, speaking with us from the University of Benin Teaching Hospital, Benin City, Nigeria. I'll be speaking with us on the topic substance use disorders in schizophrenia. And in the course of the presentation, we'll be looking at the current strategy, the novel approach to managing persons with schizophrenia and the co-occurring substance use disorders.
Dr. Oderinde, we can't see your slide at the moment. It's telling us that WhatsApp needs to be updated, and I'm just wondering if you need to close one of your windows.
Okay. All right.
Yeah, we need to get rid of that green WhatsApp screen. Thank you.
Okay. Is that okay?
No, we can still see the screen, the WhatsApp screen.
Okay.
Your presentation is behind it, so if in the top right-hand corner you exit that window, we'll be able to see your slides. Yes, and then if you remove the one for Microsoft, we'll be able to see the slides. Thank you.
Okay.
Perfect. Thank you.
Okay. All right. In the course of this presentation, we have about 4 learning goals to accomplish. One is to master and to learn about factors influencing substance use disorders in schizophrenia. And secondly, we look at the theories in the co-occurrence of substance use disorders and schizophrenia. And thirdly, we'll try to unravel the link between substance use disorders and schizophrenia. And lastly, we also understand how to manage co-occurring substance use disorders in persons with schizophrenia. Please, can you see my second slide?
Hello, Dr. Oderinde.
Yeah.
Your presentation, your slide is behind. You can close the Microsoft Store app. Your presentation is behind it.
Okay. All right. Can you see the second slide?
No, we are just seeing the first. You can scroll down.
The first slide.
Yeah,
still on the first
the
slide.
cover page.
Second, sorry, please, the second slide.
Perhaps you can exit, try exiting presenter mode for the PowerPoint and then coming back again.
Okay. Okay.
Okay, now
Fine.
that's fine. Yeah, that's fine. Yeah.
All right.
Yes, you can.
Thank you. So in the course of this presentation, we have about 4 learning goals to accomplish. One, we'll learn about the factors influencing substance use disorders in schizophrenia. And of course, we also learned about the theories in the co-occurrence of substance use disorders and schizophrenia. And thirdly, we'll try to unravel the link between substance use disorders and schizophrenia. And of course, as substance use prevention and treatment professionals, we also try to look at how to manage persons with schizophrenia and the co-occurring substance use disorders. I'll be using this outline in the course of this lecture. We'll take a look at the brief introduction about schizophrenia, and also look at the epidemiology, the risk factors and the theories, and the link between the two conditions. And of course, we also take a look at the consequences of substance use disorders in schizophrenia. And also, we also consider the management, conclusion, recommendations, and the references. In the practice of psychiatry, schizophrenia is a major mental health disorder, and it's been said to affect 1 in every 100 persons. So the risk is about 1% in the general population. And it is pertinent to say at this juncture that schizophrenia can occur at any age, but the average age of onset in men, the average age of onset for schizophrenia tends to occur in late teens to early 20s, while in women, the average age of onset tends to occur in late 20s and early 30s. And of course, schizophrenia often affects people of all social classes. The upper social class, the middle social class, and of course the lower social class. So schizophrenia is equally prevalent in men and women. And persons with schizophrenia are often present with some obvious clinical features. One of these is disorganized thinking, which is otherwise referred to as a formal thought disorder. Persons with schizophrenia, from their speech, they tend to switch from one theme to another theme without any logical connection. They may also have some bizarre behavior. You may see a person with schizophrenia talking to himself or herself, or smiling or laughing to himself for no apparent reason. And of course, they may also exhibit affect that is inappropriate to situations. And there are symptoms we often call the positive symptoms of schizophrenia. And they may also have florid auditory hallucinations. They may present and complain that they hear voices discussing or commenting about them. And some of them may have beliefs or what we regard to as delusions, believing that their thoughts, their actions, their emotions are being controlled by external agency. They tend to have very strange or bizarre experiences, which we often refer to as somatic passivity experiences. They believe that their actions, their feelings are controlled by some forces outside. And again, they may also have thought system abnormality. They may believe that their thoughts are being withdrawn. They may believe that their thoughts are being broadcast, or believe that their thoughts are being inserted into them. And of course, they may also have what we call delusional perception. Delusional perception is a misinterpretation of a normal person. A person with traffic light turning red, they may interpret that as meaning a violent accident just occurred. And of course, delusional perception is strongly suggestive or even diagnostic of schizophrenia. And some persons with schizophrenia may also have some negative symptoms, such as evolution, lack of motivation to do tasks or to do activities. They may show apathy, they may be unmotivated, and of course, they may also have anhedonia, that is a lack of interest in pleasurable activities. At this point, I would like to say that the diagnosis of schizophrenia is based entirely on the psychiatric history and mental state examination. And, it is also important to say at this juncture that there is no blood test or no laboratory test to diagnose schizophrenia. So it is incumbent on the clinician or the substance use professional to be very thorough in taking a very comprehensive psychiatric history and doing the mental state examination to arrive at the clinical impression of schizophrenia. And of course, on the other hand, substance use disorder is defined as a problem pattern of substance use, leading to clinically significant impairment in the person's life. That is a pattern of substance use that is causing some health problems or social problems in such individual, or a situation where the person in question may not be able to fulfill some major role obligations, both at work, at home. Then, of course, it has got into a clinically significant state. Substance use disorders are prevalent co-occurring disorders among persons with schizophrenia. And it's been read that 80% of persons with schizophrenia will at one point in their lifetime develop substance use disorders. And of course, most studies here in Nigeria, Bureje et al. 2016, and even outside Nigeria, most studies have reported that more than 75% of all persons with schizophrenia have a substance use disorders. So we can conveniently assert that substance use disorder is the most frequent and clinically significant comorbidity among persons with schizophrenia. And of course, persons with schizophrenia may abuse all kinds of psychoactive substances, but the substances frequently misused by this group of persons are tobacco, alcohol, cannabis, and cocaine. And it's also been reported that cigarette smoking has been reported in about 70 to 90% of persons with schizophrenia. It is also important to note here that the impact on the cause of schizophrenia with effects varying by type of substance. For instance, a person with schizophrenia who misuses alcohol, over time, such an individual may develop alcoholic liver disease, or may develop alcoholic dementia, or may even have a very weak immunity over time, which may make the system not unable to fight infection. And same with a person with schizophrenia who uses cannabis. Over time, such individual may develop breathing problems and may be at high risk of having the
Hello. Dr. Oderinde. Hello, Dr. Oderinde. We cannot hear you. Hello?
Unfortunately, we seem to be having some tech.
Yeah.
Okay,
I'm back
Dr.
now.
Oderinde. Okay, thank you.
Can everyone hear me?
Yes, we can hear you.
There are many factors that could of some disorders. All right, thank you. There are many factors that could influence the risk of substance use disorders in persons with schizophrenia. And of course, Opataku et al. Here in Nigeria, in their study to assess the social demographic factors associated with psychoactive substance use among persons with schizophrenia, they reported that there are certain demographic factors, such as being of younger age, being single, and being unemployed, that could influence the risk of substance use disorders in persons with schizophrenia. And of course, the availability of substances in our environment and the affordability of substances in our environment also tend to influence the risk of substance use disorders in persons with schizophrenia. And of course, family history of substance use, history of certain like depression, or even some stressful situations have been found as factors influencing the risk of substance use disorders in persons with schizophrenia. A number of theories have been advanced over time to explain the co-occurrence of substance use disorders in persons with schizophrenia. First is the hypothesis stress theory, also called the vulnerability stress theory. Some refer to it as a two-hit model. And this theory posits that interaction between genetic predispositions and environmental stressor, in this case substance use, in vulnerable individuals tends to precipitate the onset of schizophrenia. That interaction between neurobiology ability and environmental stressors in vulnerable individuals often the onset of schizophrenia. And there's the self-medication theory, which posits that persons with schizophrenia self-medicate. That is, they use substances in a bid to reduce symptoms of schizophrenia or lessen the effects of antipsychotics, or even use substances in a bid to reduce some of the cognitive deficits often seen in schizophrenia. And of course, there is also accumulative risk factor theory, which suggests that persons with schizophrenia may have a greater risk of substance use disorder as a result of the aggregate effects of poor cognitive functioning, poor social functioning, poor vocational functioning, all of which are known risk factors of substance use problem. There's also the reward circuitry dysfunction theory, which suggests that a substance use disorder may be related to a dysfunction of the brain reward circuit in persons with schizophrenia. The brain tends to control and regulate pleasure craving. It's been reported that malfunctioning of this brain reward circuit in persons with schizophrenia will account for the co-occurrence of substance use disorders in persons with schizophrenia. And of course, this brain reward circuit comprises of so many structures in the brain, ranging from the ventral striatum, the ventral pallidum, the anterior cingulate cortex, the orbital prefrontal cortex. So these structures tend to regulate our craving and also regulate the ability to feel a pleasure. So when this circuit is distorted, of course, it may account for the co-occurrence of substance use problem in this group of persons. Now, at this juncture, I will talk on the nexus, the connection between substance use disorders and schizophrenia. I must say here that there is of evidence that suggests that there is some nexus, some relationship between the substance use problem could act as a precipitating factor for the onset of schizophrenia, especially in persons who already have the genetic vulnerability to developing schizophrenia. And of course, a substance use problem could also serve as a perpetuating factor that could prolong or worsen the course of schizophrenia. And it's also been reported that substance use problem could form part of the prodromal phase of schizophrenia. That the use of substance could be part of the prodromal phase of schizophrenia. That is, before the flourish symptoms of schizophrenia begin to emerge, the use of substance itself could be part of the prodromal phase in persons with schizophrenia. And it is pertinent to also say at this juncture that substance use or substance abuse does not cause schizophrenia, but it can act as an environmental trigger, especially in persons with already existing genetic risk factors for schizophrenia. People with schizophrenia tend to have much higher rates of substance use disorders, alcohol, tobacco, cannabis, and cocaine than the general population. And the study by Kehinde et al. Among non-Hispanic European American participants with schizophrenia, they found that 47% of people with schizophrenia tend to struggle with substance or alcohol use problem, as opposed to 16% who don't have schizophrenia. There are many consequences of substance use disorders in schizophrenia, and this range from increased suicidal risk, increased violent tendencies, and also be increased medical morbidity that may be accompanying physical health problems following the use of substance use in this group of persons. And it may also to reduce social functioning and oftentimes more hospital stays in our various facilities. And of course, poor compliance to mental health treatment is one of the very notable consequences of substance use disorders in this group of persons. And of course, there may be also homelessness in this group of persons. How do we manage persons with schizophrenia and co-occurring substance use disorder. I'll be using the NICE guidelines. The NICE guidelines is the National Institute for Clinical Excellence clinical guidelines. These are evidence-based recommendations for managing persons with schizophrenia and the co-occurring substance use problem. First, all persons with schizophrenia first need some level of stabilization of psychosis through medication before the substance use problem intervention will begin. Having done that, the clinician or the substance use professional must ensure that the individual has adequate insight so that your intervention for the substance use disorder can make a significant meaning to the person. And it is also important to take a very comprehensive substance use history from the patient. Ask questions around the age of onset of use of substance, the frequency of use. You ask questions from the patient and also make some corroboration from the family members. And of course, assessment is also key in the course of managing this group of persons. And the assessment could be done using some self-report screening questionnaires, like the CAGE alcohol questionnaire, the audit, that's the alcohol use disorder identification test questionnaire. We may also use the drug abuse screening test. These are screening instruments that we use in the course of assessing this group.
Hello, Dr. Oderinde. We can't hear you again.
Hello?
Okay.
Can you hear me now?
Yes,
all right.
We can.
All right, thank you very much. In the course of management, it is also very important to build a respectful, trusting, and non-judgmental relationship with the patient. Professional, it's expected of us to be impartial, dispassionate, and open-minded to the patient. And of course, efforts must be made to encourage family members, the caregivers, and significant others to be involved in the management. The family is key in managing this group of persons. Of course, information about the negative consequences of substance use is quite important. And in the course of managing this group of persons, it is also important to assess the patient's level of motivation to know the stage of readiness for change in this group of persons. And this can be done using Prochaska and P. Clement model of motivation to know which stage this individual or this person is in the course of management. Perhaps is at pre-contemplation, or perhaps is at the preparation phase. And of course, decisional balance is another motivational assessment tool that will also be deployed in the course of assessing the level of motivation of this group of persons. And what is unique about this is that the patient is asked to talk about the pros and cons of substance use behavior. Usually, persons with schizophrenia who are motivated are likely to talk more about the disadvantages, the adverse consequences of substance use to them. But those who are not motivated enough are likely to talk about the gains, the advantages that they derive from this, from the use of substances. I must let us know at this juncture that substance use disorders in schizophrenia could pose some unique challenges, and these challenges are best addressed through integrated treatment program, or what is otherwise called the unified or non-segregated treatment program. So I must say here that integrated treatment program is the new standard of care for this group of persons. And when I say integrated treatment program, this has to do with pharmacotherapeutic intervention, the psychotherapeutic intervention, and multidisciplinary intervention. So it's more of holistic care in the course of managing this group of persons. So with regards to pharmacotherapy for substance use disorders in schizophrenia, the choice of medications to treat substance use problems or substance use disorders in schizophrenia varies according to the specific substances involved. For instance, a person with schizophrenia who has alcohol use problem, and naltrexone, which is an opioid antagonist, at a dose of 50 to 100 milligrams daily, has been found to be of help to this group of persons. Or person with schizophrenia who has opioid use problem, and naltrexone at a dose of 50 to 100 milligrams daily has been found to be of help to this group of persons. And of course, in person with schizophrenia who has tobacco use problem, it's been reported that bupropion, which is an atypical antidepressant, at a dose of 150 milligrams daily, has been found to be of help to help reduce craving for tobacco in this group of persons. And of course, the National Institute of Clinical Excellence clinical guidelines, they also recommend the use of atypical antipsychotics, or what is otherwise called the second generation antipsychotics, the newer antipsychotics, as the first line of choice for this group of persons. And these atypical antipsychotics include the aripiprazole, olanzapine, and quetiapine. And Wagner and Antin in 2010, in their research, they also found that these atypical antipsychotics, the aripiprazole, the olanzapine, and quetiapine, seem to have some degree of anti-craving property in this group of persons. And of course, for motivated patients with schizophrenia, clozapine has been found to significantly reduce cravings in this cohort. And it must also be said here that persons with schizophrenia and comorbid substance use problem, they may have a poor compliance to treatment. Oftentimes, compliance to oral medication may be quite challenging. And consequent to this, the use of atypical long-acting injectables have been found to be of substantial help than conventional injectables. These are injections that are released very slowly in the system. Oftentimes, it's given once in a month or given twice in a month. And these atypical long-acting injectables tend to have less side effects when compared to the conventional injectables. And it must also be made known that as substance use professionals, as clinicians, managing the persons with schizophrenia and co-occurring substance use problem, efforts should be made to avoid medications with addiction potentials, One of these is benzexol. Benzexol is an anticholinergic used in psychiatric practice. And oftentimes, patients with substance use problem may become addicted, so to speak, to benzexol because of the mood elevating property. So as much as possible, efforts should be made not to use medications that have potential for addiction. So same with benzodiazepines as well. But I must also say here that when patients with schizophrenia and co-occurrence substance use problem, should they develop side effects following the use of psychotropics, the benzexazole could be used for just few days, maybe for like 3 to 5 days, and thereafter discontinued to avoid possible dependence on this group of medications. It is also pivotal to note here that psychological interventions are key. They play a very critical role in managing this group of persons. So apart from the pharmacotherapeutic intervention, of note, of importance, is the place of psychological interventions for managing this group of persons. And one of these is the motivational enhancement therapy. This is specifically designed to evoke internally motivated change in this group of persons. And of course, this therapy often it works by helping the individuals learn how to change some thoughts and some behavior. Also, cognitive behavioral therapy is being found to also be of help. And of course, this is focused on helping the individual identify, challenge some irrational thoughts, some dysfunctional thoughts that contribute to their substance use. And what the CBT, the cognitive behavioral therapy, also help to teaching them some basic coping skills to stress, to relapses, and so on. And of course, assertive communication skills also play a very crucial role in managing this group of persons. Because we found that when these persons are assertive, that will help boost their self-confidence, and they'll be able to stand up for their own point of view while still respecting the views, the beliefs, and the rest of others. And the social skills training is also part of psychological intervention that could be deployed in managing this group of persons. And the social skills training oftentimes help the individual to know how to interact with relatives, with family members, with friends. And of course, will also help them to know how to interact in social situations where there is availability of alcohol and psychoactive substance use. Management too is also critical. It's also very in managing this group of persons. What is done in contingency management is more of behavioral therapy, often to reward positive behaviors in this group of persons, positive behaviors that could lead to healthy, drug-free life. Patients can be rewarded with a token. This has been found to reduce the frequency of relapse in this group of persons. And there is also a place for psychosocial or what I call a vocational therapy or occupational therapy, because the two disorders, substance use problem and schizophrenia, tend to have a very profound adverse effect on occupational functioning of this group of persons because of the impact, the negative impact of substance use on the patient. They might have lost some skills, and the substance professional needs to work in conjunction with occupational therapists who will help to identify the strengths, the resources, the values of this person in a bid to have a template for recovery and even acquisition of vocational skills. So the vocational therapy occupational therapy is quite very important in managing this group of persons. So in conclusion, I want to reiterate here that treating persons with substance use problems in schizophrenia oftentimes require modifications to treatment approaches that will be of help to engage and retain these persons in treatment in a bid to achieve best outcomes. So I want to recommend that there is need for training and retraining of substance use professionals in identification, evaluation, and management of co-occurring disorders in persons with schizophrenia. And of course, as clinicians and substance use professionals, it is important to have a high index of suspicion of SUD in persons with schizophrenia. That is, clinicians and substance use professionals must keep possible substance use problem clearly in mind when evaluating and treating this group of persons with schizophrenia. And of course, more researches still need to be done in our climate, especially on substance use disorders among persons with schizophrenia. These are my references. Thank you for listening.
I would say thank you, Dr. Oderinde, for a very beautiful presentation, quite exhaustive. And from the things that you have discussed today, you've brought to light that substance use and schizophrenia is more of it's rather the norm than the exception, and that clinicians and also public health practitioners should take note of that. It's more like a double burden, so to speak. So we would give opportunities at this time for questions, and I know already that we already have some questions. Dr. Oderinde, are you there?
Yes, I'm here.
Okay.
I can hear you, sir.
All right. I know you said categorically during your presentation that individuals, that we should disabuse ourselves from that notion that substance use disorders or substance use causes schizophrenia. And in relation to this, there's a question from, let me just get the name again. There's a question that was written here from Associate Professor P. Kapoa Dortu here, Jr. from Liberia. He says, well, he commends you for the beautiful presentation, and he asks, will one be correct to say that schizophrenia may be substance use caused? If yes, how can one reconcile this with the statement that there is no lab test for schizophrenia? Thinking that perhaps some clinical findings, e.g. brain scans, could report confirmation of use of some psychoactive substances in people with schizophrenia. Do you understand the question?
All right. Yes, okay. I got the question.
Okay.
Of course, as I said in the course of my presentation,
okay,
that substance, there's no blood test to diagnose schizophrenia, but that does not mean that clinicians or substance professionals mustn't order for some other investigations to support and in the course of managing this group of persons. And of course, there may be need for some brain imaging, the brain CT, But from clinical evaluation, one may get about 80% of your findings that will suggest your impression of schizophrenia from clinical evaluation. The investigations, like the radiological investigations, the CT, the MRI, may just be to lend credence to what you have already gotten from your clinical findings.
Okay. And what of his, so you use, because I know in your presentation you had said substance use does not cause schizophrenia. So he's asking that question, does substance use cause schizophrenia? I don't know if you could comment on that.
All right, thank you. Well, substance use may cause schizophrenia only in persons who already have genetic vulnerability to developing schizophrenia. So substance use is just, in this case, more of a precipitating factor for the onset of schizophrenia. So in persons who are genetically vulnerable to developing schizophrenia, the substance use could now act as an environmental trigger for onset of schizophrenia. But for some persons who don't have that vulnerability to developing schizophrenia, the substance use may just cause a schizophrenia-like illness, which as soon as the substances are eliminated from the system, the schizophrenia-like psychotic illness will disappear over time. So that also forms the basis of the diathesis stress model I spoke on earlier, that the interaction between neurobiologic vulnerability and environmental stressor will account for the co-occurrence of substance use disorders in persons with schizophrenia. So in response to your question, substance use does not cause schizophrenia directly, except in persons who already have strong family history of schizophrenia, or persons who are already vulnerable to developing schizophrenia.
Okay, thank you very much for that exhaustive answer that you have provided. I hope that the person who asked the question has been is satisfied with what you have said, which I believe is very exhaustive. Someone else wants to ask. I'll ask this question, then I think Ejikeme can then go on to ask another question. The person is commending you for the presentation and asking, is it correct to say that people with schizophrenia are cannabis friendly? Is it correct to say that people with schizophrenia are cannabis friendly?
Well, I must say that there's a wealth of evidence that also suggests that there's some degree of association between cannabis use and schizophrenia. In fact, some have reported that chronic use of cannabis for at least 10 years could over time lead to onset of schizophrenia. Now, in response to your question that persons with schizophrenia are cannabis friendly, well, we may take a cue from the self-medication theory that I spoke about earlier. Usually, persons with schizophrenia tend to use psychoactive substances ranging from cannabis, tobacco, to relieve some symptoms of schizophrenia. Some persons with schizophrenia that have very florid hallucinations. For instance, from anecdotal experience here in the course of my practice, some persons who have schizophrenia who have very florid hallucinations, and maybe in the course of history taking, they may tell you that, oh, they also spoke in their head. And one of the reasons that they often say, they often share with us, is that, doc, this cannabis tends to knock off the voices I do here. And that also supports the theories, the self-medication theory. So we can say that, we may say rather, that person with schizophrenia, they may be cannabis friendly because of the effects, so to speak, that they do get from it to relieving their symptoms. But of course, that is not the way to go.
Yeah, thank you very much. And I think you've also, at some point in your lecture, buttressed the fact that even though drug use can precipitate schizophrenia in vulnerable persons, drug use itself also leads to certain brain changes. And I think a takeaway for us as practitioners and for those as trainers and teachers or substance use professionals will be, because sometimes carers come in and they are quite frustrated that their relative who is using psychoactive drug and has a mental illness. But from what we've learned from your lecture today is to continue to encourage supportive treatment that allows medications to be, they should continue to take their medications. That's one of the things that you have shared with us today, and not say that because they're also using drugs as well, then they are hopeless cases. So thank you for that. So Ejikeme, over to other questions. I think we can take one or two more for time's sake. Yeah, over to you.
Okay, thank you so much, Dr. Babo. And thank you, Dr. Oderinde, for the excellent presentation. Someone sent in a question and they said he doesn't know how to make use of the chat box. So the question goes, can antipsychotic medicines used in treating schizophrenia help to reduce drug dependence? Can antipsychotic medicines used in treating schizophrenia help in reducing substance use dependence?
Well, basically, the antipsychotics used in treating persons with schizophrenia are to basically address the psychotic symptoms that accompany schizophrenia. But there are some antipsychotics that have been found to have some anti-craving property, which I said in the course of the lecture. But antipsychotics are basically to treat psychotic symptoms in schizophrenia. But aripiprazole, olanzapine, and quetiapine, in a research by Wagner et al. In 2016, reported that these three antipsychotics seem to have some anti-craving property in persons with schizophrenia. So my response to the question is this: the antipsychotics used in schizophrenia treat psychotic symptoms, but there are some that may have anti-craving property. So I recommend that it is better to start this for persons on atypical antipsychotics, which are newer medications, which are newer antipsychotics. Aripiprazole, olanzapine, quetiapine, they are newer antipsychotics. And this group of persons tend to tolerate them better than using conventional antipsychotics.
Okay, thank you so much. And just this last one, someone wants to know what schizotypal personality means.
Okay. All right. A schizotypal personality and schizophrenia, let me take it that way. There's some relationship, so to speak, between some personality disorders and schizophrenia. But of the various personality disorders, the schizotypal and the schizoid have been found to be personality disorders that are predisposing factors to onset of schizophrenia. Now, schizotypal personality, this group of persons may be withdrawn. They may have some very odd beliefs. They may have some esoteric or magical thinking. So the kind of presentation or features seen in persons with schizotypal seem to share some similarities with persons with schizophrenia. And it's also very reported that the features seen in schizotypal personality disorder could be vulnerability tendency for onset of schizophrenia. So the features seen in schizotypal personality disorder seem to be related with that thing in schizophrenia.
Okay, we are out of time, so we may not be able to take more questions. I'd like to hand over to Dr. Bawo so that we can round up the discussion.
Okay, yeah, thank you very much. And I know that what we've listened today is really very rich. The presenter today may not be able to answer more questions, just like Mijikeme has said. But just the question someone has asked, if everyone with schizophrenia uses substances. No. I think the presenter said up to 70% may have used psychoactive substance at one point in the duration, in the course of their illness. So it's not everyone who has schizophrenia that uses. And then to the other question, I think there was one other question about, will the resources be made available? Yes, it's usually, I think that the presenter is open to sharing the resource, and it will be made available. If you're present on the ISSUP Nigeria WhatsApp group, it's usually shared on there as well. And also the video of this presentation, the organizers, Olivia will make it available on the ISSUP YouTube channel, and also on the ISSUP website. The resource is also available, so you can go to these locations to access the resource. So thank you very much again, Dr. Oderinde, for bringing to point the intersection between mental illness and psychoactive substance use. It's a double barrel really that we have to manage. And one major thing to deal with is the attitude that we have as professionals, because we usually carry on those attitudes from the community, because we're very averse to people who use drugs, and sometimes people who suffer from schizophrenia, we then add that stigma onto them. And very, very, very happy that you've pointed out the biological nature of this disorder. You've also let us know the way to manage it and the strategies to use. I'm hoping that when ISSUP Nigeria invites you again, you could probably share more with us, your experience and other management tools. So thank you to all the attendees who have attended today. We apologize for the internet issues we had at some point during the presentation. Thank you very much for joining. Have a lovely day, wherever you are. Bye.